Welcome everyone to the second episode of the podcast of Le GIC, which is the Quebec Cardiology and Cardiac Surgery Interest Group, which is a student initiative, medical students. And today on this episode, we have the honor to welcome Dr. David Drullinsky, and we're also welcomed with two other medical students, so Raouf and Viviane. So I'll let you guys introduce yourselves really quickly.
Hello, my name is Viviane. I'm a Med 3 at McGill University.
Hi, my name is Raouf, and I'm a first-year medical student at Montréal.
Perfect. And I forgot to say my name, but I'm Ahmed, and I'm also a second-year medical student. And Viviane has the honors to welcome Dr. Drullinsky.
Yes, so I'll just quickly introduce Dr. Drullinsky. He's originally from Santiago, Chile, completed his medical degree at the University of the Chile in 2010 before moving to Montreal. He conducted research at McGill University in 2013 and completed his cardiac surgery residency in 2019. He then pursued a 2-year fellowship at Northwestern University in Chicago, focusing on heart transplantation, medical circulatory support, and complex valve surgery. He also joined the Western University in London, Ontario, specializing in advanced heart failure surgery, including VADs, ECMOs, and transplant. He returned to Montreal in 2024 to join the SHIM as a cardiac surgeon, and then while completing also contributing to McGill transplant program. Now he works at the MUHC and is serving as a staff surgeon at the Royal Vic Hospital and assistant professor of surgery at McGill University. He's focusing on heart transplantation, mechanical support, and complex coronary surgeries and atrial fibrillation. He's also doing a master and health profession education at Maastricht University. So we're very welcoming Dr. Drullinsky today. It's a pleasure to have you on our podcast.
Thank you. Thank you so much. I'm very happy to be here.
Good. So if we can start by our first question. So my first question is, what inspired you to become a cardiac surgeon?
Oof, it's a tough question. I mean, some people had a very clear path and a clear inspiration or a moment that just lit up in their minds and it happened. For me, I don't think it was like that. It was a little bit of serendipity. I during med school, I changed my interest like 18 times. I started with psychiatry, oncology, orthopedics. I moved around a lot. I think every rotation I had, I really liked it. When I did ortho, it's my first surgical rotation. I think I really fell in love with the surgical approach to things. I thought it was because of ortho, which is a very nice specialty, but I think it's more the fact of doing surgery. And then when I was in Chile, I was a med student. I had the opportunity to come to McGill to do an elective. I have a friend who's an anesthesiologist at the General Hospital. His son was my classmate in high school, and that's how we knew each other. And so he asked me, "What do you want to do? What do you want to come and see?" I had no clue. So I asked him, what do you think would be good? He said, look, you could do some heart surgery, pediatric heart surgery. That'd be interesting. I know the people there. So he introduced me to Dr. Chervenkov and some of the other cardiac surgeons here. And I was able to come here for an elective for 2 months. And that was it. I think it took like 3 days of me seeing heart surgery to realize that's what I liked. But it was very random, very serendipitous that I ended up doing that rotation. I think if I wouldn't have come for that elective, I probably wouldn't be a cardiac surgeon. I don't know if I would have found my way into it. So,
wow. So you wouldn't say that there was like a particular moment that brought you to like your specialty right now?
I mean, I think it was that. It was just the chance that anesthetist had a good relationship with the cardiac surgeons and thought that would be a good thing to come to see for a month. And because I don't think I would have done an elective in cardiac surgery at all if I wouldn't have had that rotation. And then I would have for sure chosen general surgery. That's what I wanted at that time. And I probably would have, stayed that path. So I would think it would have been unlikely that I would have become a cardiac surgeon if it wasn't for that. So, but that's how life works. I probably would be as happy doing something else, but it's what I love right now, and that's what it is.
I was gonna ask a follow-up with that. You sort of talked a little bit about like who you the doctors you've met and other like you said that he introduced you to a certain doctor, and well, how would you grade like the importance of mentorship through like the training of medical the training to become
it's a good question, because I think our model of education and medicine is still a mentorship model. You could think, if you compare it about, like, if you can compare it to some other very common path, would be, say you want to be in computer engineering and code. It's a very technical skill, just like medicine is very technical, but you can learn it from a video, and coders don't think about coders they want to mimic. We think about doctors we want to be like, and we see them not just doing the medical act itself, but everything else that they do. We kind of want to emulate that, and I think we learn a lot like that. And there's the mentorship part, and there's the cultural, the whole medical culture that we adopt, and we change, I think, who we are during medical school, and we change the perception of ourselves during medical school to become, or at least see ourselves as doctors. And I don't think it's something we do. I think it's something we become. Medicine. We don't do medicine. We become doctors. And I think that's very different than many other professions. And I think that that's why the mentorship role is so important in medicine still. And it's something that goes back, probably as long as we have recorded history. Healers were learning from other healers. And I think it's what we've been doing, and what we'll probably keep doing in spite of all the changes that we're seeing today. I think it's still the one of the most important parts of our profession.
Mm-hmm. On the same note, would you say we're born to handle the stress, or you're built to handle the stress? And how do you do it?
I think we're all different. I think there's people that can, I don't know if it's handle the stress, but it's more be able to accomplish the objective in spite of the stress, or and we're all different on how we cope and how we get through the situations, and that's fine. And there's going to be people in our fields who can can go through heart surgery, who can go through trauma situations, who can go to CPRs and codes, and they're going to be able to do this without any without any stress. And people who won't, and they'll find a way to do something else in medicine where it's not an issue for them. And I think that we are also fortunate in that it's so varied what we can do as doctors, that you can find something that fits your personality. So if you're bad under stress, that's fine. There's a lot of things you can do that don't require you to be good under stress. If you're, and everything has its advantages, disadvantages, right? You can say we sometimes don't think so much about things. We just act as surgeons, which is good when you need to do that, but it's bad when you shouldn't be doing that, when you should be thinking more about it. So I think our personalities fit the specialty we choose, and sometimes also we change the way we perceive, or we develop mechanisms to be able to be different and adapt to whatever challenges we face.
And like bouncing off of that, because a lot of students have the same question. What was your realization that you wanted to be a surgeon and not in internal medicine, and not something a bit more, because that's the big question as students.
I think a lot of people want to know that, and I don't know how it works for everybody. I think we're all different, and we go through different paths and processes to get there. But for me, I don't think it was like this complicated thing. I just felt an affinity towards surgical specialties because I like, instant, feedback from what I do. I like to put a stitch and stop a bleeding, and oh yeah, it stopped. I see it. I don't have to wait 3 days to see what happened, right? So I think that fit a lot with myself, and I don't think there was a specific like life-changing moment. I don't think there was a big thing that changed my path or anything like that. I think it's just I gravitated towards it, and I think that's what happens to a lot of people. We might attribute events or situations where we say, "Oh, that was it," but I think a lot of it is just a gradual process of we see which specialties, which rotations we're more comfortable with, which what are we, which days are we more excited to wake up in the morning, if it's to go do a medical rotation or to go do a surgical rotation. And you kind of if at the end of the day you're like, that was a terrible day, I hope it's not like that, versus a day where you're like, oh my God, that was awesome, I hope it happens more. You kind of get the feeling of where you should be, what kind of things you like, right?
For sure.
All right. So I'll follow up with another question. What would you say, like, all during the whole training, from medical student to learning to become a surgeon, would you say is like the hardest or the biggest challenge you had to face?
I don't know. I don't think it's I think it's more personal challenges outside that are unrelated to whatever was happening. I feel like becoming a doctor, you have a lot of challenges. It's not easy, but it's part of it. It's fine. There was nothing for me in my path, and I'm very fortunate that I feel like everything was sort of easy in a way, in that everything tends to work out. And I think that many times we drown ourselves in glasses of water because it's just our perspective. We're there and we're facing it, but I think things work out, and things find the way. And if plan A fails, it's fine. There's plan B, C, D, E, and I think that that's one of the things I would tell medical students. If it's the CARMS match and you don't get your specialty, you might feel it's the end of your life. It's not. You'll be fine. It's you're whatever you do, you'll be fine. Even if you don't do the specialty that you think you want to do, it doesn't matter. Like it's not just that in your life that's gonna bring you happiness. And in medicine, there's so many specialties that are good and that they're fun to do, and that we we kind of sort of tunnel vision towards one thing, and sometimes miss out on great opportunities that are next to us. And I think that's what I would tell medical students: enjoy the path to get there, and you never know where you're going to end up, and it's fine. It's you only get one life, so if there's one thing that doesn't go your way, that's not going to be the end of it.
So what would be like the advice you would tell to young aspiring doctors to get to your specialty?
I don't think I have any advice to give them to say, like, this is what's going to get you into cardiac surgery, because there's no recipe. There's nothing that this is what you need to do, and you'll be a lot of it, like it happened with me, was serendipity. I'm an immigrant. I did medical school in Chile, and I was lucky that everything worked out my way when I came in, that it was the right time, the right place. I had the right fit with the people, and it there were a lot of paths that I was trying at the same time that didn't work out, right? So it's a little bit about the observer bias where, well, I feel like I succeeded because I'm here and this is the path I got. But who knows what the other paths would have got me to, right? So it's hard to know, right? You make the decisions that you think are right at the time, and you make the best of it. It's tough. I know it's a really hard period of life for medical students, especially in our reality where the options are limited, spots are limited, and you kind of fixate on one thing that you want to do. But my biggest advice is, don't worry. Like, it's gonna be fine. Whatever happens, it's gonna be fine, right? You're doctors in one of the best countries in the world with the most opportunities and safety, and you're gonna have a great life. It's more what you make of it that matters, not so much decisions of other people, because that's what it is. For who gets into which residency, a lot of times you do your best, but it's not up to you, right? So you can't control everything.
I think that's very well said, and it's gonna comfort a lot of our students that are listening, because a lot of us are like that, and a lot of us are.
Yeah. And it's the thing when the people would tell us, relax, you'll be fine, doesn't matter. You can't. It's you're going through it, you're in it, it sucks. But it's just from the other side, it's gonna work out. Whatever happens, it's gonna work out. There's 1,000 fantastic specialties and jobs you can have. That's not just one. And I think that way. If by ABC reasons I would be an oncologist today, I'd still be happy. It's still good. It's I'm sure you find the best. You guys can do anything. You made it this far in medical school. It's that by itself is so huge that you have to think that it's not about which specialty you get. They're all great, you know, and even if you don't do the one you want the most, it might be for the best. You never know.
Yeah, I agree. I think as students, we really need to hear that, because it seems as when we're in the medical field, or like as students, we want to do something, like you said, we have tunnel vision, and we just forget to enjoy the path, you know, the ride along. Yeah.
It's the trip that matters. And look, from my experience, I all I wanted was a job at McGill. All I wanted. And I finished my training and there was no jobs at McGill. So I went to London, Ontario, and I thought, oh my God. And it was great. I loved it. It was, you know, fantastic 2.5 years I spent there. And, you know, it made me who I am today. It's part of my path, right? And I was not happy when I started there, right? Because it's not what I wanted. I wanted to live here in Montreal. I wanted to be at McGill, and I didn't get that. But it was great. And I probably, maybe if I wouldn't have done that and it would have just started at McGill, I wouldn't be doing what I'm doing today, right? So it helped me out. And then I wanted a job in Montreal, and I got a job at the CHUM, not at McGill. And I took it, and guess what? I didn't like it so much, right? And it's fine. I was able to switch to come here, and if I wouldn't have been able to come here, I would have gone somewhere else. And you know, it's about how you face things and how you think about them more than what actually is happening, right? And that's the thing that you guys have to work at, is how to be happy with the path you get. You do your best, and then, but you know, it's not just about that final outcome, because it's also never final. It can change.
I think that's very well said. And I think, again, a lot of us think, like, for example, the observation day, the one observation day in the operating room is, oh, I like it or either I don't, and I have to choose now. Or the 2 weeks or 3 week electives that they had in internal medicine, did I like it, did I not? I have to choose for the rest of my life. But as a student, it's not the same as a resident, which is not the same as a doctor. So I think it's also very good to go into things a bit open and optimistic to whatever life leads.
100%. Look, and that's another good point. When you think about residency, especially in cardiac surgery, a lot of students think about the residency itself. You know, it's a tough program. 6 years, it's a long time. You're gonna be in it a lot, and you're not gonna see your families or your friends. You're gonna be working a lot, and it's tough, but it's temporary. And I think that the main thing to focus when you're choosing what you want to do more than the residency is the practice. So, you know, fine, the residents, they work a lot, but talk to the staff and see how their day-to-days are. What do they do? How much, you know, how much they get to do that's outside the hospital and outside their work. And I think that's much more important if you're looking at your wellness and balance than what happens to the residents. You might also even ask them on a bad week, and they might tell you it's terrible, right? So I don't think I think for choosing specialty, try to ask more the staff than the residents, because it's just a temporary, you know, part of life. It will go by fast.
Yeah, I think you touched base on one of our question also. Can you describe what a typical day in your life as a cardiac surgeon looks like?
Yeah. It depends. I mean, there's different types of days, and I would say the main division is going to be surgical days or OR days and non-OR days. So in an OR day, usually I'm in the hospital around 7 a.m. And then you know, during the day I do surgery. So I'm mostly doing that. Those days are really, there's not much else going on. I don't really have time for anything, and it depends. Average, you know, the time that we finish, I would say between 5 and 6. It's our average. Some days are going to go to 10. Other days I'm going to finish at 3. Right? And it really depends on the cases, the patients, luck, how quickly other people work and move and stuff like that. And then usually those days you have to be sort of around and available, because sometimes the patients get sick. You have to go back to the operating room. So they're very demanding on your availability. Then there's clinic days. Usually that's if there's no meetings or anything, we start around 9, our clinics here. So that means I can be in the hospital at 8:30. Sometimes I get to have breakfast with my kid before, and those days are relaxed. There's no rushing. We do have sometimes a lot of patients in clinic, but that's fine. We get through that. And usually by 3 p.m. we're done. 3, 4 p.m. I'm home. There's always meetings and office work and stuff like that. I tend not to do that. If I tend to say, well, I'm done at this time. If there's stuff left, there's stuff left. I'm not gonna, sometimes I don't answer your emails and stuff like that because I try not to bring that home or stay too late if I can get out. So, but other people have different approaches. And then there's research days and academic days and all that stuff. With that, I make it more my own, however I feel. I always have like a morning here and there to answer all the emails that I haven't been able to answer during the week and go through stuff and plan things.
Good. I mean, you're pretty good at answering my email, so
I don't feel I am, but I think most emails I'll get will get an answer. The thing is how far back, and I try to be better. I saw an interview by Tim Cook, I think it was, from Apple, and I think it was him. And he said that one thing he started doing was to dedicate the first half hour of the day only to answer emails. But then after that half hour, he doesn't check his emails anymore. But so he does it routinely, that he has a period dedicated to it, but then he's not a slave to it, right? Because you kind of want to answer your emails, but you don't want to be doing that nonstop. And I think that's the problem with our brains. That's another topic, but how the phones broke our brains, that we're always available and answering texts and interrupting in-person conversations for a text message that I think our brain can't prioritize what's more important. So I think you have to make an effort to do that and separate work from life.
Yeah.
Well, I have another question, maybe more surgically related, but what was the most complex surgery you had to go through? Either by time or like just mentally fatiguing?
I don't know. It's hard to tell you, and it's because, I mean, there's always big surgeries and tough stuff, and I do transplants and left ventricular assist devices and dissections. They're always tough, but it's hard to tell you that there was one that really marked me. And our minds work in a way that we kind of focus on the recent and forget about the past in those terms. So it's hard to tell you, what was the most challenging. I mean, it's always challenged to lose a patient in the operating room. That's rare, and when it happens, it's not a good day. I think those are the most challenging things that we have, is those that even in the OR you can't fix, and that's always a big those patients are heavy in our minds. Usually we usually remember them, right? Those are patients we don't forget. Like in 5 years of practice, it's happened to me 2 or 3 times. So they're rare. They're not as common, but when they do, they mark you a bit.
Sorry to hear that.
It's okay.
I think that's also it's like a misconception of cardiac surgery, because a lot of people are like, oh, well, cardiac surgery is basically the last resort, and usually the surgeons are the one doing they're trying their best, but they're doing the wrong move, and it's already, that's kind of the reason. But was it hard talking about that specific those like those moments? Was it hard for you that first time, that it was kind of like you were in the operating room and a patient passed away? Like, how did you encounter that?
Yeah, it's hard. I mean, we see a lot of patients die in general in medicine. We see a lot of people die, and we sort of get used to. We know how to deal with it. But it's hard when you're the person who met with the patient or the family before and tell them, look, I think I got help. I think I can make it better. I think the chances are fair that we're gonna have a good result, and then it doesn't work that way, and it's frustrating. It's difficult. You feel terrible, but it's again, it comes with the job, and it's part of it, and it's going to happen, and it's going to happen to all of us, and it's something you just have to get used to, and everybody deals with it differently. And it's always tough. I don't think any surgeon has a easy time with those cases. And no one likes to lose patients, but it's some people cope with things differently, and it's up to you how you deal with that.
Yeah. So for people who's telling like the surgeon are only like technical skilled, how important is empathy compared to like the technical ability you have to do in surgery?
Yeah, I mean it's a cardiac surgery is a very technical specialty. We have to do a lot of things that other specialties don't do a lot of, and that they're you do have to have a facility with this kind of things to make it easier on you. It's not that it's necessary, so and it's hard. I mean, it's hard to understand because there's a thing of how good you are with your hands. But in reality, I think the main thing is your judgment. That's what really marks you. I think most people can do the suturing. It's not that hard. You learn to do it. The problem is the judgment of when you do what and how, and I think that's the difference of good surgeons and not so good surgeons. It's judgment, and a lot of times patients you lose, it's probably you shouldn't have operated on them, and maybe a more experienced surgeon would have realized that, or they would have had a better judgment, or there's a lot of things like that, and it's not as easy as it sounds sometimes, and we get the feeling that people outside our specialty think it's black and white, but it's not, and there's a lot of things that end up reaching that outcome, and I know there's some studies on this about how do you get to mortality, how do you get to a death, right? And I know there's a study like that. I forget the name of the methodology. I know there's one in LVADs that I read a few years ago and I found very interesting of, fine, there's mortality. What leads to that, right? And it's not just saying, oh, he died of an infection. What led to the infection? And what led to that? And then what they did in that study was start to differentiate different paths that patients could take. And they could track them from day one. And certain patterns would end up in certain outcomes. And they could actually differentiate that. And it's very interesting to see that's a chain of events. It's not one thing that kills our patients. It's a chain of events. And that's why I think judgment is so important. And because you're going to say, well, what does it have to do, my judgment, with the fact that the patient died of a pneumonia 2 days after surgery? Well, maybe it does. Maybe there's something that you could have recognized different and done something different. And I think that's a lot of what artificial intelligence is going to help us in this, is to be able to recognize these patterns that our brains are not able to get to. I don't know if I went on a tangent there.
No, it's perfect because our next question is about AI. In like, what's the biggest change in cardiac surgery from the moment you started medical school in Chile and now in 2025? And is there technologies that you can actually apply today? Well, obviously there are, but like what are they?
Look, it's hard to tell because first I switched environments quite a bit. I didn't get a lot of cardiac surgery exposure in Chile. I trained at a public hospital that was very poor, especially compared to anything you would see here. And then they did have a cardiac surgery service that would shut down September, October because it would run out of funding for the rest of the year, right? So after that date, there was no cardiac surgery whatsoever. It would completely close. So if you imagine, it's very different to what we're doing here. So I just by the fact of changing countries, I got to see completely different things and resources and techniques that you would never dream of in that center in Chile, just because of resources. Now that's not the only place in Chile doing heart surgery. There's a lot of variability, and there's private centers that have a lot more resources and money and things that they can do. Right, cardiac surgery is expensive, and all the fancy toys are expensive. But I would say there's maybe three changes in the last 20 years in general in cardiac surgery. One, it's been a tendency towards minimally invasive, and that means smaller incisions, alternate incisions, and no incisions, although it's just smaller incisions, which is, TAVI, for instance, is a technology that's changed the field. It's a smaller incision. It's not a no incision operation. It's just a very small incision in the groin. So, you know, those kind of advancements have changed a little bit what we do, and they're great. I mean, I work with the TAVI group, and what we do with those kind of valves, it's amazing. I mean, if you're able to save a patient from an operation, they can go home the same day or the day after, and they don't have a scar, and they have the same result. It's really, really good, right? So I think that's a big change. Same as minimally invasive surgery. We tend to see that, I think, more and more. It used to be sort of niche where certain surgeons in certain centers would do it. Now it's most centers probably should have a minimally invasive surgeon. I think those are big changes. Another thing that's been big for us, it's been outcomes research and knowing your outcomes. We tend to kind of know how we do in terms of we know our mortalities, we know our success rates, we know all these things, we know how much money we spend in the OR. We know it as a group, we know it as a surgeon. So I think that knowing that in other specialties don't have that as well. There's no feedback that you can get about how you're doing as quick as we do in cardiac surgery. I think it's we're well positioned for that. And that started 20, 30 years ago, but now we're living in an era where we can see it fairly, you know, widespread, and our hospital knows our outcomes, and they tell us. Yeah.
And how do you think your role will evolve in like the next 10 to 20 years?
It's hard to say. I don't think, you know, in medicine, it's hard to change things too quickly, not just because of the operators, the doctors, but because patients and systems, and, you know, we see the changes with AI in other fields versus ours. I mean, I think I use AI a lot in my day-to-day, but it's not widespread. Most people are not using it, and it doesn't change much for them. It just makes my life easier to use it. I think you know, I think these kind of things they're gonna come to our fields. We're gonna do research with that. We're gonna use it. But to say, well, you know what, in 5 years you're not gonna need family doctors because you're just gonna use AI. I think it's just dumb to say something like that, because the the system is it has a lot of inertia. It won't change that quick. You won't have all the patients going to see a virtual doc. And I don't think it will work out right away. I think it's what's going to end up happening, but I don't think it's going to be that quick as it can be with other things, where, you know, you might go see a virtual car salesman because, you know, it's cheaper for the company to have that, and who cares, right?
Yeah.
I have another question, but it's maybe not so related with the last few questions we got, but
that's fine.
Do you balance just your work with your personal life, and do you even succeed in doing so, or like, did you find something that works for you? Or
yeah, it's not bad. I mean, I think it's all up to you, and I you have to set limits. You have to work on it. You have to be proactive. It's not a passive skill. It's an active thing. So, you know, you can easily get lost in your work. You can very easily say yes every time someone asks you to do something. It's hard to say no, but and then, you know, you could be working like crazy. And I know surgeons that, and I do that a little bit, and I know surgeons that do it at the extreme, especially the ones that are super successful in the academic world. It's you know, they go to presentations, they travel a lot, they're always in the circuit, plus their clinical responsibilities, plus teaching, plus this, they end up neglecting the outside life. And I've seen a lot of people that happens to, they realize it and they have to change things, and it's hard to do it then. So the best way to do it is be cognizant of that at the beginning. And I try to limit how much I do. And one of the rules I have is when I go home, I usually don't do any work, right? Unless it's clinical work when I'm on call and I need to answer phone calls and stuff like that. But I tend not to grab my computer and do anything at home. And I'll find times during the days, and I'll find times I'll stay maybe half an hour later during my regular days of clinic or something to do extra work. But I try to fit it in all during my work week, and that's it. Because I think at home you're at home. And that, again, that's one of our main problems is multitasking. We should think that that was a positive thing. As I think it's a very negative thing. I think we have to focus on one thing, not multitask.
Yeah, that's great insight. And would you say you have some habits that maybe you started earlier in your medical career, even before you were a surgeon, that stayed and maybe helped you in this work balance?
Yeah, it's hard to tell. It's hard to tell. I think the thing I work on the hardest and that gives me the most pain is this thing. I think the phones are bad, and I think cell phones are destroying our brains, and I'm very much against it. I'm completely enslaved by it. I can't get rid of it. I've tried many things, and I think it's one of my biggest problems. I don't have any social media because of that. I don't think social media per se is bad. I just think it's addictive, and so I don't have any Instagram, any LinkedIn, or any of that. I try to keep my phone as empty as possible of all that, but it's still very difficult to escape it. And I don't know. I sometimes I think we should go back to dumb phones just because, but I think it's impossible at this point. And I that's what I recommend to you guys. Like when you're studying, when you're doing stuff, leave your phone in another house. Keep it as far as possible as you can because it's just impossible to get away from it. I don't know if it's my personality, but it's so bad.
It's not just you.
Yeah. That
I
we
mean,
can assure you, we're all like this, I think.
I know. I mean, sometimes you're talking to people face to face, and we're on our phones texting, and it's rude. It's not good. It's defeats the purpose. And I think we could do better. And I think that's one thing that worries me a lot, especially having young children. I think my brain got changed by my cell phone, and I don't want the same thing to happen to my kids. It's probably even worse for them because at least I got a cell phone. Maybe probably you guys too got cell phones when you were still in development. I was like 22 when I got a cell phone. So,
Yeah, but I think it's very important to still address that because a lot of people, again, misconceptions about surgery in general. They think like, oh, surgeons don't have a life. Oh, they regret it and they're just in the hospital 24/7. But it's important to also address that we can have some sort of balance.
Oh yeah, like look, I mean, if you ask my wife, she would want me to be less on call. Oh, it's impossible. But you can always find a place. When I was in London, we were 9 surgeons, so I had a lot of time off. I had a lot of weekends off, a lot of breakfast with my son and before school and things like that, which to me are very important. And I think that you can always achieve that. And I don't think it's the specialty the problem. I think it's you the problem.
So you think also it changes from city to city, country to country. That also plays a big factor.
Yeah, and I think also the newer generations were different too. I mean the more the boomer generation and even Gen X. I'm half Gen X, half millennial, sort of depends on how you look at it. But they were more into you have to work as much as you can. And when I talk to my dad, he's like that. You have to work, and why are you not working? You need to make more money. You need to do this. It's the time to work. But our generations, or well, I don't want to say our. I mean, my generation, we're more into that's not the main thing. You have to make a separation. I'm sure the newer generations, your generation, and even the ones after, they're even more into that. I mean, it's just look at how the problems they have hiring people now is not that there's no candidates for jobs. It's just that people don't want to do a bad job. They want to work in a place that's not good, right?
For sure.
So I think it's going to be better, and people are more understanding of that too. I mean, the more I took 2 weeks off for paternity, and a lot of people were like, oh, "That's not enough. Why are you taking so little?" And I have my own reasons, which is we have so much help at home that I know that if I take more time off, it's not useful, and I'd rather postpone it and take it later on, which is what I did. But for and that's great. I mean, I felt good that people were telling me you should take more time off, which I felt rare. In the U.S., when I took 1 week and 2 weeks off paternity, they were upset I didn't take one because the normal was one, right? So I think that things are changing a bit.
Well, 1 week is not enough. You don't have any time to rest.
That's crazy. It's crazy. I said no. I said no. I'm taking 2 weeks. Thank you. But yeah. there's different mentalities, different things. I mean, Canada, we have paternity, which in the US, it's really not a thing. Right? Here we can take, 2-3 months and it's fine. I don't want to do that, but we're also autonomous workers, so you don't. It means 2-3 months without income. But it's also for me. I found I have too much help at home. With my wife's whole family was there, so I was just twiddling my thumbs. So that's why I didn't take that much.
Good. On that note, we don't want to keep you away from your family long enough. I don't have any more questions. I don't know if the guys have other questions for Dr. Drullinsky.
Well, I was just gonna say before we wrap up, if you had like a last word to say, or just maybe not even just for medical students, but maybe something, an advice or an action that someone could implement by tomorrow that would make their life so much easier.
I think it's the approach. Enjoy life. It's short. You never know what's going to happen. And if you ask most people at my age group or my, where I am or even older, the main thing that they would want is to go back in time and be in your shoes instead of our shoes, right? It's life is so good. Being young is good. The med school years are great. Residency years are great. And it goes fast. So enjoy it. It's all you're gonna find good stuff everywhere. So just enjoy what you're going through.
Well, thank you so much. Really appreciate the insights.
Yeah, no problem. No problem.
Yeah, thank you so much. Thank you so much for our invitation. Yeah.
No problem. It's a pleasure. Take care, guys.
Thank you.
Thank you.
Bye.
Have a good evening. Bye.
You too.
Good
Bye.
evening.